Good evening, everybody. This evening we're doing a hangout on commissioning for integrated care. With us today is our host, Matthew Horn, Nick Faint from the local authority in Southend, Sue Luff from Kent, and Jay Johns from Barking, Havering and Redbridge. You can join in today by tweeting at care2_share or using the hashtag #IntegrationPioneers. I'll hand you over to Matthew, who will take it on from
there. Thank you very much, Frank. My name is Matthew Horn from the Innovation Unit. I'm very pleased to be facilitating this conversation this evening. As Frank said, we're going to look at commissioning for integrated care. Before we start, I'm going to ask each of our participants to introduce themselves. So can we start, please, with Nick?
Yes, good evening, everybody. I'm Nick Faint. I'm the Programme Manager for the Pioneer Programme at Southend.
Thank you. And Sue?
Hi, I'm Sue Luff. I'm the Head of Commissioning for Ashford CCG.
Thank you. And Jay?
Hi, I'm Dr. Jay John. I'm a GP in Barking and Dagenham, Clinical Director for the CCG in Barking and Dagenham, and lead for the Prime Minister's Challenge Fund for BHR economies.
Thank you very much. Thank you very much, everyone. We're hoping that Roland Scanlon is going to join us from Monitor shortly, and he will join as soon as he can log in. So the way we're going to run this, we're going to have a short presentation from one of our colleagues here, followed by questions for clarification and then discussion. And I've asked our presenters to really focus on what are the major challenges and difficulties in relation to commissioning for integrated care. We're going to start, first of all, with Nick from Southend. So, Nick, if you'd like to take us through really the situation in Southend. Somebody's daughter, I think, has just woken up. Colleagues, if you have serious background noise, then do feel free to mute your microphone at some point. So, Nick, take us through the context for commissioning integrated care in Southend, please.
Yeah, no problem. If I just share my screen. So we should. So where I thought, can everyone see that on the screen? Is that okay? Everyone can see that clearly?
Yeah.
Yeah. So where I thought I'd start was just by way of a short update of where we are in Southend. And I've tried to sort of itemise this in bullet form so everyone can just sort of follow me as I go down. At Southend, we have a resource issue generally across the programme and within the council and the CCG and the hospital, but it's quite acute in that it has had an impact on some of the areas, particularly so the programme management role. I've now taken over that role, and I took over 2.5 weeks ago. So where we are in terms of update is that I've been busy handing over from the previous programme manager and in sort of listening mode. So whilst it's not essentially halted progress, but it has meant that there's been some, we've tried as much as possible to get a seamless transition, and I guess in some cases that's had a lesser or greater degree of impact. So that's where we are from that perspective. The other perspective is the recruitment of resources within the programme and to deliver the work streams has been very difficult. We're a local authority, and whilst we're just over 30 miles from London, it's not a great place. It's a difficult place for people to get to, people of particular experiences in both the commissioning and the operational world. So we've been struggling to recruit the resources, and I think that's partly on availability, but also I think that's the expectations that we have as a council in terms of the skill that we were going to get. So certainly over the course of the last couple of weeks, I've been trying to understand those expectations and manage them. We have, I'm not sure how similar we are to other Pioneer programmes, but we have a number of work streams. We have 3 key or core work streams running through the programme, and 2 work streams that sit across each of those 3 work streams. The first one is the prevention and engagement work stream, And we have that now defined. We've got owners, we've got workstream leads for that. So we have the definition of what we're trying to achieve in that workstream, and that's sort of seeing that when I arrived has caused me to do some challenge around that. But I think that's quite well. Oh, that's advanced, that one. We are beginning to scope the work required within the other work streams, so particularly the commissioning and the operations, and the information and governance and the communications work stream. So the info and governance and the communications sit across the three work streams. So the plan is to have all of those do some very sort of specific and targeted activity about defining those work streams and have them complete and signed off through our governance process by the end of June. And I'm not necessarily anticipating a huge amount of issues in that process, other than the sort of the sign-off issue or the sign-off process. We've as I'm sure most of you have similar issues or similar kind of issues, is that we've been trying to manage the issues that are presented from an ever-changing health economy, and that is very much about there's a huge amount of change, both driven by financial and sort of structural changes being delivered within the health economy and their health partners. And more specifically, we've had the local CSU to us, or that supply or that we commission, has decided that they are going to cease, and that is due for realisation in September. So that has caused both the CCG and the local health partners to reevaluate what it is particularly they want from a commissioning work stream, but also a commissioning role, and how that feeds into joint commissioning particularly, and what that looks like. And we're getting into quite a lot of detailed discussions about that, but at a very high level. So from my perspective, it's about sort of stakeholder buy-in. And we've got, as I'm sure a number of you are aware, very poorly performing acute trust from an A&E perspective, and we are, as a pioneer programme, we are looking at the ways in which we can support the recovery of the A&E department. So that's essentially an update on the programme. I think my next slide, if I can just flick over to the next one. No, it's not there. There it is. This is about the challenges that we envisage that we're going to face, and some of them we are facing, and some of them we think we're going to face. So I'm interested in people's views on that. From my perspective, and this is, I've titled these in the governance section, is that it's about alignment of the vision and the cultures. And I think what I mean by that is that we across each of the partners within Southend, whilst we've got sort of quite senior buy-in to what we're trying to achieve, I think particularly with regard to joint commissioning, I think there's going to be challenges around just what do people mean by joint commissioning, and what does that look like actually on the ground, and how does that manifest itself, and all of those things, and around culture as well. There's conversations at a senior level about sort of combining back office functions, and that to me presents is a really exciting opportunity, but it presents some real strong challenges that we need to kind of engage with and make sure that we're addressing. One of the other challenges that I've got, that I think that we're going to encounter from a governance perspective, but also commissioning, is that we've got quite. I think one of the reasons why we were successful in achieving pioneer status was that we have a good track record in innovation and joint commissioning of services, and I think that there is expectations there both at a national and a local level, and I think the challenge will be trying to rationalise what is achievable and building on the track record that we've got, and not duplicating but doing new innovative things. We've got a track record of doing it, so the challenge is going to be set to continue doing that. The next point is that we've got a very strong voluntary sector. It's very well coordinated. I think there's a lot of issues within the Southend area that the voluntary sector can add value to and address. And I think that we need to somehow, as a programme, harness that in our commissioning activity and make sure that or engage with the voluntary sector so that they are part of the commissioning process for us, so that they, from an operational perspective as well. So that's one of the challenges. And I think that the last challenge, particularly in the governance section, is about balancing ambitions with actually what is real and what is practically delivered. We've got a real opportunity in Southend in that we've got a blank sheet of paper at the moment and we need to write down and list and structure out what it is we want to deliver. And I think stakeholders will have the ambition, and I guess it's the programme it's the programme managers and the workstream leads challenge to make sure that we don't just write everything down and set about trying to deliver everything around commissioning and joint commissioning. So and we actually weed out from that what we think we can deliver in the time frames, and we make it real so that people do see a real difference. The challenges that I think, particularly from a commissioning perspective, and whilst these two are, the governance and the commissioning are, in my opinion, are aligned, is one around approaches, procurement, and resources. The approach is how do we align both commissioning approaches that exist across all the partners, particularly around the conversations that are joint commissioning activity, and how do we help the sort of local economy manage the supply, and how do we manage the demand. And it's those sort of things. The procurement is that we need to work very closely with our procuring and commercial partners to make sure that what we're saying that we want to commission and what we want the outcome to be is actually delivered through procurement and the commercial aspects. And the resources, and I think this is quite a relevant point from Southend's perspective, is that we're continually faced with budget cuts. We've got legislative changes coming in, particularly around the sort of the social services, the social care aspect, and we've got the sort of the back office functions to think about. So they're the challenges that I think we're going to face from a commissioning angle. I'm not sure if anyone has a similar view on challenges or whether it's something completely different, but if they are completely different, then I will caveat it with saying that I've only been in place for 2 weeks.
Okay, thank you, Nick.
Thank you.
Nick, very, very helpful, kind of wide-ranging set of issues there for us to pick up. I just want to pick up on one of the things you mentioned, which was really around the track record locally in relation to joint commissioning. Can you give us some examples of where you think that's gone really well in Southend?
Yeah, I think we have a number of examples. I think one of the examples that I'd like to draw out is we have a function or a mechanism called the spore, which is a single point of referral. And what that helps us do is it helps from a reablement perspective, but it also helps GPs keep patients who would, maybe in other areas go to an A&E department, but it helps those GPs refer the patients who may need some support, medical interventions or social care interventions, but it can be done in their independent living space where they're residing. And it also helps the hospital discharge patients into a supported living space, i.e. independent living. What that looks like on the ground, and it's particularly relevant because I went to see it this week, and it was very interesting. It was really good to see how it worked. There are social care workers, there's occupational therapists, there are district nurses, there are a whole host of resources from across all the partners that are manning the phones, and they get phone calls from the hospital that they've got a patient who had a fall, needs to be discharged but needs some care from a provider, needs some providing care commission, and that's sort of advised through the spore, and equally from the beginning of the life cycle, we've got GPs who refer patients to the spore, and then their sort of needs are met. I also witnessed or sat in on a meeting where a number of cases were talked about anonymously, and was very interested to see how it actually works. And case by case, these issues, patients were discussed, and their issues were talked through, and a consensus was reached across all the partners that were sat around the table as to the next course of action. And what that meant for me is that kept patients who might in other areas be referred to back into A&E or into some other form of assistance. And the whole solution, it did seem to work. It's not been easy, I don't think. In terms of process, I think when they started there was very little budget, there were very little resources, and it's kind of grown. But it was really interesting to see it work. Does that help, Matthew?
Yeah. And that was jointly commissioned by the local authority and
the CCGs
and his predecessor.
Yes.
And from and how's the money flow from that? Does money flow from both of those commissioning organisations? Are there two contracts? There's one contract. How's that managed?
No, it's kind of that's an interesting point, and it's certainly something that we've been talking about after. Cheryl from the innovation unit, our account manager came down to see it as well, and we talked very much about that. It's not commissioned under a single contract at the moment. The money flow is at best, I would say, complicated, because it's not that clear how the money flows through. I think there's a bunch of people there that are very keen on making on delivering a solution, and I think they're leaving that side of things to the organisations to sort out. It's going to fall into the commissioning work stream to actually bring together perhaps a pooled budget where you can then actually jointly commission those services, and you can actually pay for them out of one budget. So it's by no means a finished article. I think for me, what I took away was that it is possible, and I think where there's a will, there's a way, and you can actually sort of make it happen. So,
okay, thank you. I'm going to go to Jay. Jay, do you have any questions for Nick, please?
In terms of joint commissioning, has there been a lot of work for the Better Care Fund in terms of moving forward between the CCG and the local authority? Because obviously we're in a similar.
Yeah, I think it's that's quite an interesting question, particularly given the sort of the national noise around the Better Care Fund at the moment, and certainly the stuff that's coming out publicly about that. I think that we have there is a huge amount of enthusiasm to help to enable the Pioneer programme to deliver the actions that we've allocated within the BCF. I think from all partners there is a great deal of enthusiasm for that to happen. I think the challenge will be, or not the complications so much, but the issue is going to be, as has come out in the national sort of context, about actually defining the benefits around so you've been given this pot of money, what benefits when you've spent that does that deliver to the other partners? And I think everyone's sort of sat on the sidelines at the moment to actually they've got their own aspirations of what the Better Care Fund is going to deliver, and they may be different to other partners' or aspirations. And my role, I think, is to try and tease that out of our partners and to try and understand where they want the Better Care Fund to benefit their organisation and where it can benefit it, and it's kind of doing the gap between that. So where we are specifically in that is that we have the detail around the benefits that we think we're going to deliver. We need to develop an action plan, a specific action plan about how they are going to be delivered, and just assure each of the partners that when we say a benefit of X amount of pounds, that it actually means X amount of pounds, and this is what it means for you as an organisation as to what you can then achieve with that. So are you in a similar position to that, or are you more advanced? Or
probably a little bit more advanced in that respect, because I'll talk about in my presentation. But just keen to know where, because I do see it as a vehicle for integrated commissioning, and like you said, for the reasons that you elaborated. So yeah, I think you're right. I think what you've said is absolutely true.
Jay, do you have any other questions you'd like to raise?
The only issue is obviously we come from a slightly different predicament because we've had a bit of priming for our integration. But I think the biggest fear I worry about, our sites, our colleagues like yourselves, is obviously because of the like you said, the kind of funding, the funding spiral that seems to be going ever downward. There needs to be a bit of priming, I think, to get it forward, because some of it needs to be tested, and I think that's the biggest fear, isn't it? Really.
Yeah, no, I agree.
Okay, let me bring in Sue here. Sue, do you have any questions, please, for Nick?
So I just wondered about your membership engagement. Just really, I think that's the bit that we're struggling with, is just really our primary care capacity and our membership engagement. And have you got any bright ideas for that, and what's happened in your area?
When you talk about membership engagement, do you
obviously we're from a CCG, so we're
yeah.
a membership organisation, so it's just really taking them with us,
Yeah.
And,
yeah.
And I'm sure GP colleague, some absolutely 100% get it, but like any other organisation, there are the odd individuals that we need to take with us, really.
Yeah, I think I don't know. In my first week, I was asked down to the voluntary sector kind of. They do a get together every month, and it just happened to be the first week that I joined, and I was asked to prepare a presentation and give a presentation on the Pioneer Fund, the Pioneer Programme to the voluntary sector, those that were attended. And when I sat down and thought about the structure of the presentation, I thought there's a lot. What's in our favour at Southend? And actually, when I listed it down, there was a huge amount in our favour. And I think this may not give you any kind of answers to your question, but we've been quite fortunate in the circumstances that have been presented, in that we have a very poorly performing acute trust from an A&E perspective. We have a CCG who have been thrown into a position where their CSU has decided to cease to trade. So we've almost been thrown together as partners, and it's almost the chief operating officer from the CCG is very, very signed up to it. She's very actively involved in the development of the Pioneer Programme and all of the other commissioning activity within the sort of as you would expect her to be, but very much rolled up, sleeves rolled up into the details. So very interested. We've got a very we've got a chief exec at the council who's very signed into, very signed up to this. He's very active in terms of developing. So I think we've got really good senior sponsorship across all of the members or the partners within the programme, because of course when we're in local authority and we talk about members, we talk about something completely different. So we talk about the politics more. So I think that's point number one, that we've got senior sponsorship. Point number two is that we have a set of circumstances that that have enabled that buy-in. I think it's very difficult to kind of to add to that because there's it's a cultural thing as well, isn't it? It's actually trying to work out what how the cultures are aligned, all the sort of the visions and the strategic, how the local area team fits into all of that and what support they give. And my take at the moment is that it's quite positive. We are a unitary authority. We have a single CCG. We're centred around an acute trust. So there's other things in our favour as well. But I understand from other region or other programmes that they're probably not as in a fortunate position, but they'll have other things going for them. So
Nick, can I come in there? Because it sounds like so some of those factors are in your favour. Although in particular when the beginning of your presentation was about resource constraints and how actually the situation has sort of thrown a lot of the partners together of necessity.
Yeah.
But actually getting buy-in from all the different parts of the health economy to this is critical. We've had a tweet from Beth Kappa who says getting all the right people to the table for joined-up commissioning is key, given the stretched resource that we've got. What tips have you got for getting all the different partners involved? I just wondered, Sue, whether or not you could share with us any sort of advice or tips you've got about how do you reach out to the whole of the primary care community and the local authority partners and secondary care providers? Can you share some advice or some experiences?
Well, I mean, I think for us, I mean, we are quite fortunate. I mean, our difficulty, we've got 4 different CCGs in our area, so we're quite lucky in our CCGs. We have some really, keen clinical leads, and they've shown really good, strong leadership this past year, and so it's about us using their skills and their sort of enthusiasm to take some of their colleagues along. Really, I think the thing that's starting to excite primary care is around some of our aspirations around our community work, because they can truly see the benefits of that for them. And for us, that's sort of been a bit of a light bulb moment for them, is once they can see what's in it for them and what's in it for their patients, that then really starts to get them engaged. I think, to be fair to the GPs, he knows that it's been a bit of a hangover from the old PCT days, in that they felt very much done to, didn't they, with the PCT? So it's just really changing that culture, that actually they're part of that now. They absolutely can drive the health economy forward. So I suppose from my point of view, it's just putting the effort in about communicating. I mean, I meet every practice on a monthly basis. It's a nightmare, but that's what I do to keep them on board, and keep them sort of going with me and with our team.
So how many practices is that?
Well, I'm fortunate in Ashford. I've only got 15 practices, so it's not too bad. But our clinical leads have a bi-monthly meeting with the GPs, just to tell them where they are with their programs. We've really invested in the amount of time that we spend with those practices, communicating with them. I would say our biggest. I mean, I think the thing about primary care is not that they don't want to go forward. They do, but they just can't see the wood for the trees at the moment, because everything's been thrown at primary care. And I say, so one of our biggest issues is with our relationship between our providers, but I'll come on to that later.
Very good. So selling the benefits to patients, and selling the benefits to primary care practitioners. That model of, I presume that happens across all of your 4 CCGs, that engagement with each practice on a regular basis.
Yeah.
I wonder if I could bring in Jay here, whether or not you can say anything about engaging secondary care, because this, in particular in relation to commissioning and changes to commissioning for integrated care, have you had any success in BHR?
Well, very similar to where Nick had come from. Our BHR economy in terms of the hospital is in dire straits and monitor, and I think practically everyone has been in to our hospital to say how bad things are. But that has actually given us a vehicle or opportunity to say, look, you can't do what you're doing, you're just too busy. You're not getting the outcomes that you hope to get. You have to do things differently. For everyone, and in actual fact, I think our local hospitals actually welcomed the whole integrated. They realise there are some real, I would say, disadvantages for the hospital, but when a system can't cope, and primary care, and I mean primary care as the whole community, are saying that we could do more or do things differently, and we could, look after your patients. I think actually they've been actually quite welcoming, and I think they just need to see, and particularly a lot of the clinical teams, they need to see what exactly you're going to do, because a lot of the problems we have in accident emergency and as well as the wards is the fear of what will happen to the patient when they leave. So I think that once there's a good dialogue, they understand the benefits, then I think ideally they will come to the table and they will come to discuss things. And particularly for our speciality consultants, when you say to them, look, I don't know, I've got a patient particularly with very bad COPD, and we can give support in between your outpatient appointment, or you can tell us what you can be involved with their care plan in the community. Actually, it changes the mindset, and I think there's a degree of cohesiveness that comes with it, because everyone's on board, especially the patient or the carer, because they know exactly what's going on. So it may be that our particular circumstances that has driven us to that, but I see it as an opportunity rather than a negativity.
Thank you. Well, Joe, I wondered, can we stay with you, and can you just move us into your sort of 5 minutes on commissioning integrated care in BHR, and some of the reflections you have on some of the biggest challenges and difficulties?
Sure. So very similar to our previous speaker, our health economy is in dire straits within the hospital. Overperformance, poor quality, poor patient experience. There has been some improvements, but nothing near to the level that we need to be at in terms of the rest of the country. The only thing I would also say is that because of this, there's been the NHS, the TDA, all these big agencies have been involved. They really are pushing this collaborative work so far. But in terms of our community, we with our local authority, we have integrated care teams like many of the other sites. We, for the last 3 years, 2.5 years now, where we have community GPs, district nurses, practice nurses, matrons, social workers, and mental health practitioners within clusters within GP practices, which has been collaboratively done. Further to that, in terms of setting up, because our one hospital supports 3 CCGs, the Barking, Havering and Redbridge CCG, we have had to do a lot of, with the local authorities, a lot of joint systems. So we have a joint assessment and discharge system within the hospitals, which all 3 local authorities have invested in and supported, as well as having CCG support. Further to that, we've also, in terms of co-commissioning, we, using our Section 75 agreements, as well as looking at piece of work for our frequent flyers or frequent attenders, we co-commissioned social workers with mental health skills, because we found there was a lot of patients who were re-attending hospitals with mental health issues, who could do with different roles within the local authority to help support these kind of patients. Further to that, in terms of integrated commissioning, we've mapped out through the Better Care Fund between the local authorities and the CCG exactly on the. We've looked at key objectives and key things that we'd like to do together. We've both collaboratively looked at outcomes that we'd like to do. So, for example, with local authority, reducing the number of residential care, real things that local authority have to deal with, and we look at other aspects for us, like reducing the admissions and looking at improvements in the quality of care with our primary care teams and so on. So we've done this mapping exercise. We've got shared outcomes. We've looked at, through the Better Care Fund piece of work, we've looked at where there was things that we could improve on. So there were things that we weren't very happy with in terms of carers and the voluntary sector. So collaboratively, we've had to put that in through this mapping exercise to support shared objectives for improvements in end-of-life care and obviously supporting carers. Further to that, we were successful in getting the Prime Minister's Challenge Fund, which was a £5.6 million investment and using that, we've used that some about GP access, improving GP access within the community, but also further to that, the more exciting thing for me is having a complete complex care team based on the highest number of long-term conditions. And this was based on the year of care work that some of our partners have been involved with. And what we've looked at is actually commissioning a team that has the full team from day one, so a GP, consultant, district nurse, matron, social worker, and that's done collaboratively with that. We have to roll out within the next 4 weeks. We've been given it. It's got huge deadlines that we have to do, and by the end of the year, we will have had 1,000 patients commissioned by this complex care team, which is a completely separate new entity which has been commissioned completely through this money as well as the local authority and CCGs. And by doing that, and obviously priming all of this, we hope to obviously take money out of the acute trust to fund it further in the long term. Further to that, we've also looked at co-commissioning in terms of things like education. So we have a huge end-of-life project we've used one of the hospices to do training of end-of-life care, and we've been careful to not only train, for example, our GPs and our practice teams, but also the social workers, carers, as part of all of this, using this money to do a kind of more system approach, so having a real innovation that way. And further to that is we were always waiting for the shared care record kind of thing. We never really got there. So out of the 5.6, a large chunk of it is actually to create a IT infrastructure through the whole system, so that any practice can access any patient's notes, and equally they can be shared with our social worker, a local authority team, as well as our community teams and our local trust. And the benefit of that is that wherever you put the system, they'll have the most amount of information. Wherever the patient gets seen, everyone will have the information to hand, and that was for me, that's a real win, and that's being rolled out we hope, by the 1st of July, the first week of July, that infrastructure will be in place. In terms of, so based on that, we will have this we'll have this specific team that is basically a whole team, holistic team for the very kind of needy or the most complex patients. And then further to that, and we will build on that, based on that, our other teams that work in the community as such. And our BCF, as well as our quick plans, are all based, they're kind of support the co-commissioning and the future commissioning of integrated care. And that's how we've mapped it out. Now, as for the primary care question, what we've done is there's been a new lot of contractual changes within primary care. For example, having a named GP lead for the over 75s, looking at reducing admissions, which is part of the contract. And what we've done is we've done a mapping exercise of the levers that are out there and that we can use to convince the primary care teams to come on board, which they are, and also to understand the levers across the whole system to bring the systems together, wherever it is. So it may be from the contracts, the GMS and PMS contracts levers, and the DESIs and LESIs, as well as looking at what other levers there are through public health, through the local authority, and so on. So we have almost like a collaborative commissioning in terms of incentives. And in terms of stakeholder engagements, we've got quite a large, complex plan in terms of to roll out side by side with the developments of the new system. So in terms of patient engagement, having all the different stakeholders, so they're completely aware. And I think In terms of the GP community, all 3 boroughs now are trying to get into a federation agreement. And the reason we prefer that is because it's very much easier for a local authority to do business with a federation, i.e. all GPs in one go, than it is to do it individually with, in Barking Dagenham there's 42 practices and having contracts for each one, and trying to manage it. The federations are in place, and the federations are also part of the governance structure for the Prime Minister's Challenge Fund, the 3 federations across the 3 different CCGs.
Okay, Jay, let me come in there. There's an awful lot in there. I want to go to Sue and then Nick first for some questions. I'm sure you want to dig into some of the details, Sue.
Well, it sounds sort of great. I'd be interested to know a little bit more about the care plan that you put in, because we're just about to hopefully launch something as well called Share My Care. So does yours actually link with the acute trust and the ambulance service and everything as well? Or?
Yes, so we've got a virtual care plan, which is accessible to carers as well as patients or the people that can use the IT. If not, it's a handheld record. But yes, the accident emergency, they can access the care plans. And what our integrated care teams do, they have to update the care plans. And how we got that updated, we made it as a KPI for our main community provider, that they have to load this on a regular basis onto their care plans. So any professional that's involved with that will link into the care plan. It's a virtual care plan that uses a system called Health Analytics, which is our kind of tool for risk profiling, as well as it takes information from primary care, social care, as well as and we've joined up with the LAS as well as the local trust who can access it. And that's why it was really important, because our teams now are actually in the community, so the social workers and our community teams and GPs are sitting in GP practices. Well, they needed something that has a common linkage. So, I think further to this, having this additional primary care ability to look into different patients' notes and so on, or to a degree, we further expanded on the actual care plans itself.
Okay, thank you.
Nick, questions for Jay?
Yeah, I think I don't think you necessarily covered it, but I'm just interested in your view. As I understand it, your area, BHR, is quite a complex and diverse, both ethnically and from a sort of a demographical point of view. It's quite a diverse. You've got a lot of diversity, which in turn brings very, very different and diverse requirements from a social care and a health needs perspective. How are you predicting the demand for those services and the type of services? How are you doing that work to make sure that the service that you're planning for at the moment is fit for purpose in 5 years' time and meets the needs, but not only that, is future proofed? And I'm asking the question because we're going through the same challenge, but I wouldn't have thought we have anywhere near as the sort of amount of challenges as you have, or complexity as you have in your area. So I'm just interested in how you're doing that, and probably generally from everyone else.
So that's a good question. That's a very big point, and it's an issue that we've been continually dialogue. So our approach is we've used a lot of public health data and Public Health England data in terms of and of course census data to look at some of the ethnicities, and where the ethnicities have also generated, they generated particular disease groups. So, for example, in my area, sickle cell anemia is a very common problem, and we have to, as a CCG, we've had to commission a sickle cell service because of that particular issue. And in terms of developing the teams, we've had the very important thing is to also have some of the stakeholder engagement. So there are cell groups, there are different ethnicities. So there's a Eastern European group. There's we've engaged with a lot of those groups to help with some of the design aspects in terms of developing what the on the ground teams feel like. Now, in terms of our year 5-10-year plan, well, although our commissioning cycles look at more year, we do have a 5-year and almost a 10-year plan of where, because we need to know how many numbers are coming in, what kind of admissions, because one of the biggest issues with outer London boroughs is that we do have this real natural population coming in and out, which provides difficulties, especially if you're building the data about these patients and they disappear and someone else comes along. It's a very complex. But that's why, in some respects, having 3 CCGs working on together, the movement between the 3 CCGs doesn't become a problem. Our integrated care teams now, before it was traditionally Barking, Dagenham, Havering and Redbridge. Now there's a lot of cross cover, because where practices that were on the borders of 2 particular boroughs, we've had to bridge some of those issues as part of this project as well. But it is a continual feed. The health and well-being of the board is actually the kind of the kind of senior governance in terms of helping shaping any issues that come up. But we do have a very clear understanding of where we are now and where we have potentially in the future, because that is, like you said, future-proofing what we do. That's where we are. So it's engaged.
So is it integrated with the social care side of things? Because is it kind of, are you from a capacity review perspective? Are you looking at what the demands of the local population will be and the different groups from both and looking at how that commission activity will work from an integrated perspective, or is it done in isolation?
No, it's actually a joint project. So, for example, some of the carers, like for example, if you've got look at some of the Asian groups of people, there tends to be a lot of families and carers that are very much involved with those particular. And they tend to be in-house, and it's how those kind of groups. Whereas you've got a completely different spectrum where you have literally almost completely dependent on the system as well. It's trying to manage both. So that's where the whole stakeholder engagement becomes. We've used a lot of Health Watch to kind of bring those kind of different views in, from the disabilities to different ethnicities and so on. And they've been very useful, in my opinion, in terms, because they do a lot of surveys, and they tend to bring in a lot of criticism of some of our plans, which helps to define some of our issues that we had. We had within our particular area, we were closing a walk-in centre, and that caused loads of issues. And it was Health Watch was quite instrumental about telling, we need you to do something different, and the CCG changed as a result, based on the evidence. But I think it's a very good point. I can't say we're 100% future-proof, but as much as we can, we've tried to do.
Okay. Jay, it's Matthew here. We've had a tweet from Simon, who says that he's concerned that often the voluntary sector is assumed to be the patient's voice, but often it can mask or hide individual patient voices. Can you just say a little bit about how you have engaged the voluntary sector and how you've used Health Watch so that you actually get to hear individual stories and individual points of view?
Yeah, so Health Watch have been quite good in developing more. It's not biased. It tends to be patient voices of the people that are very much interested. The voluntary sector, you're right. In some respects, it can be sometimes quite skewed, depending on some of the the groups and so on. But I think we tried to have a consensus group. So we had a stakeholder group as well through our own economies. We also have Health Watch, who have quite a various, because some of them were previously links and other agencies before that, so they've got quite a good kind of directory of some of the groups that they have. And we also have our own kind of, in part of the design workshops, we invite patients directly to the design, so they're literally feeding in the kind of issues that we have within our communities. The other thing that I've got to say, the local authority have actually got a really good catalogue of all the different groups out there, and and they've been really helpful in getting some of these groups. I know in Barking Dagenham, the local authority, they've had some really good ability for as a commissioner to give us an idea of what kind of people, who should we be engaging, and what groups are out there. Because I don't think we all, as GPs, I'm 100% sure I didn't know how many groups there were out there, and I think it's sometimes you have to use other organisations to help channel in some of the different voices, as well as actually having events and inviting people. Healthwatch had done newspaper adverts to bring people to come to these events. They've sent out emails. They've sent out on various ways on radio to encourage people to come to their events to talk about some of the issues that people were having and facing. So I thought it was a very good. Our first Healthwatch event had almost 120 people turn up, voicing some of the issues they have with local services, and also, they really do know what they would like in the future, what they see as a good service, and that's sometimes it's quite a difficult challenge to say. I wonder if we could do that.
Okay, thank you, Jay. I'm going to move us on. If we had more time, I would have wanted to hear more about the shared outcomes that you developed, and whether outcomes for integrated care look any different in the future. And also, I would have liked to explore a bit more the levers and incentives that you mentioned in relation to primary care. But we do need to move on. I'm going to go finally to Sue. Sue, just share with us for 5 minutes or so the journey in relation to commissioning integrated care in Kent, and what challenges and difficulties you have faced.
Okay, so East Kent has 4 CCGs, and it's important to know the geography. So we're surrounded by sea on 3 sides. We're really got a monopoly provider situation at the moment. So just bear that in mind when we go on. So we've really sort of spent the last year trying to build a framework for our vision for urgent care and community services, and what we've started doing is putting things in place. We've got integrated teams in place. We've got a local referral unit. We've started doing 7-day primary care in one of our clusters, and that team then works with the intermediate care team at weekends for discharges and so on and so forth. We've put a community geriatrician in and done lots of work around the care homes, and that's been really successful. We've got, like I say, a care plan, hopefully, that we're about to launch in June, that will link into our ambulance service, acute care, and so forth. And I would say that without doubt, we've done that with partnership with Kent County Council, and that's proved to be sort of really successful. I think our biggest challenges would be that we have got one provider in East Kent for our secondary care. We're very limited where else to go, and sometimes there is sort of competing strategies. So our strategy that we build these community hubs and these community networks doesn't always fit with the way that the acute trust wants to go, because obviously they'll lose a significant amount of income and activity. And the way we've tackled that really is by having a sort of sensible conversation about we're in this together, and this is about the health economy. And actually, if we can create that capacity, that then allows us to bring some of the work back that we currently send to London and repatriate a lot of that work, that thing. So there's benefits for all organisations. I think the biggest thing at the moment with our providers is our relationship between our secondary care and our community is been quite strained at times. And because of that, we end up getting involved in operational issues. So I'll give you an example of that, the management of the delayed transfers of care. The commissioning team were asked to go into the secondary care and lead some of those CTOP meetings to try and focus them and challenge each of the providers. And so I've been doing that at one of the sites, and that's been quite, we can't carry on with that because we haven't got the capacity, and we shouldn't have to do that, because they should be provided that function. I would say our other things are, I've spoken about primary care, and their capacity. The other thing I would say around primary care and general workforce is that, you know, we all know where we're going with better care funding and the pioneer and so on and so forth. And I suppose what I would like to see is some of those national bodies starting to think about workforce changes and putting them into place now rather than sort of 3 years hence. So we're starting to grow the skills that we need and the workforce that we need sooner rather than later. In tracking and procurement, we've actually put in some joint sequins this year across the providers to really try and force them to start working together. So we've got over 75 one, we've got a pulmonary rehab one, and so on. We're also a pioneer site, and that's great. You know, really positive, really committed. Everybody wants to go in the right way. I would say one of our challenges has been our local council. I mean, they're very keen and they absolutely want to work with us, but sometimes they do go off at a little bit of a tangent and it goes away from the strategic vision of their own county council sometimes. We have done a lot of work around our population growth with our local council, because Ashford as a town is set to have a 40% increase in population over the next 5 years. There's huge housing developments going on. So there has been, we're not there yet, we haven't got the exact detail yet, but we have started that work about mapping out what will the future of healthcare look like, so we can make sure that we've got the infrastructure there to support it, you know, when all these things are up and built. So I know time's going on, so that's just it really for me. And voluntary agencies, you know, we, again, like yourselves, have done a lot of work with voluntary agencies. We've put in a grant system where they can apply to us for grants. And then if it fits with the strategic sort of need, that's what we'll do. I would say some of our smaller voluntary agencies are struggling really. They haven't sort of the capacity and trying to get their heads around the new way of commissioning and the new way of contracting for them. It's been really difficult, and I wouldn't say that some of the national agencies sometimes support them. So if you look at Age UK locally, you know, very keen to get on and work with us, but they really get very little guidance from their national body, and so, you know, how do we try and support them in that process? And that's it from me.
Okay, thank you, Sue. I think we have got Ronan Scanlon with us from Monitor. I can't see you, Ronan, but can you hear us?
Yes, I can. Sorry, I had a few technical difficulties, so I've been listening, eagerly listening in the background.
That's great. Well, I'm sorry not to bring you in earlier. It's very good that you can be with us. I wondered, do you have any questions for Sue? And I wondered whether or not anyway, so do you have any questions for Sue, first of all?
Yeah, sure. I mean, it's obviously really interesting from Monitor's perspective to hear about the different ways in which, you know, you're each moving forward the integrated care agenda. I suppose you mentioned, Sue, the use of joint sequins just briefly, and perhaps in relation to trying to force the different providers to work together. I was wondering if perhaps you could say a little bit more about that. And just separately as well, I was listening keenly to the last speaker with regard to the use of Health Watch and perhaps some involvement with health and well-being boards. And we're interested to see, and I think there is some variation between the different commissioning areas in how proactive those two organizations are, and whether you're able to get useful data or useful feedback from them, which helps kind of inform and sort of fortify support for these different approaches. So I'd be interested to know what your experience was, if any, with those organizations as well.
Okay, so the joint sequence, if we take the over 75 ones, is we actually have a clinical forum which consists of consultants and GPs and the chief nurses from the organisations, and they met to determine what clinical outcomes we wanted for over 75s across the health economy, and really that was then so that's, you know, how we're going to measure people performing against that sort of sequence. But the sequence were all about, for over 75s, the integration was around, so if we're going to say that we're going to affect early discharge and start using the integrated care teams and you know, use the voluntary agencies, if one organisation is achieving and the other one isn't, what we can't have, what's historically they've done, if they've blamed each other, they've got to work together to sort that problem out. If we go back to the detox, for example, is my exit strategy is in 2 weeks' time I'm not going to go to their operational meetings anymore. They have to work together to sort that process out, because we can't keep getting involved in them. So I wouldn't say we're quite there with them yet. I wouldn't say the providers actually fully understand them yet, but we're a much better place than we were 6 months ago. In terms of the Health and Wellbeing Board, then what I would say is the overarching Kent one, very organised, just about to launch their strategy, just about to go out and do a joint communication exercise. I'd say the Ashford one, which obviously feeds into the Kent one, has had a few teething problems, and I think, to be fair to them, it was because of the borough council dynamic. The borough council really sort of took that over and just went off a tangent with their own agenda and not, what was needed for the health needs of the local population. So we've just really in the last week agreed a work programme with them, but it has taken all this time to do that. Health Watch really isn't very proactive in our area, which is a little bit of a problem, and our lay members for engagement are working with them to try and get them more proactive and try and get them more involved with us. But we do have a very sort of vocal patient participation group that feeds into them, and that's really been our route into them.
That's really interesting. Thank you.
So I was wondering if you could say a little bit more about your engagement with your local secondary care provider. You talked about having the 3 CCGs having one large provider in East Kent. At what levels have you had that engagement, that conversation with the hospital? And to what extent have you tried to align vision and values across all the partners involved, or if you had to accept that there are differences that are irreconcilable? Okay.
So, I mean, the engagement happens at sort of many levels. Obviously, there's the usual board-to-boards and meetings. I mean, we've invested a lot of time going, bringing the two teams together and physically going into the on-site, talking to people. Really, for us, it's just about, we've used the contract for this year to say, let's be sensible. It's not a block, it's sort of cap and collar approach, just to get an agreement over the contract to say, let's not be arguing about tariffs and contracting issues for the next 2 years, because we really need to work together to implement some of these pathways once and for all. So let's, what happens, sometimes you want to put a pathway in place and you get into a discussion with providers about we can't do that because we're going to be losing income. So let's stop that argument. Let's sort the contract out, and then that then gives us the time and the space to do the work that we need to do to work together to change things. So we've spent a lot of time getting the providers together to really talk about our vision, what is it we want to do. I would say for our urgent care, we absolutely have a shared vision. Everyone agrees that what we want is the front end of urgent care is to be primary care led, and we've tried. We've had a GP in A&E for working for the past year. That's been really successful. We're going to build on that now and put a more integrated team in there. So secondary care, absolutely on board with that. And I said before, the way we've used that is because really then just nurturing them through that process to say the benefit for them will be is that their clinicians will have the capacity to then deal with the cases that they actually need to deal with, and not the cases which are really primary care cases. So yes, they will be losing urgent care activity, but actually they can manage the trauma better. They can sort out some of their surgical issues in a much more sort of cohesive way, and they can start bringing some of the work back from London. So they've got capacity and finance, coming back to them. Sorry, I forgot what the second point of your question was.
I think you've addressed it. I think that's fine.
Okay.
Can we go to Jay now? Do you have any questions for Sue, please?
In terms of moving forward, in terms of integration as such, do you think you'll ever get to the point where you'll completely, use the budgets as really as a pooled resource, or do you think there'll still be some separation for the integration or for the integration agenda? Because I know that the BCF talks about pooled budgets as such, but you do wonder if it needs to go much further to really encourage integration. Do you have any views on that?
Yeah, I mean, I think what we feel is we need to really sort of have joint commission, have one commissioning team, and that's really the way to drive it forward. We have done some work with the Commissioning Academy, they were in a sort of small course a few years ago and did that, and that really sort of helped us to open our eyes up into the possibilities of joint commissioning. I mean, Paula, who was my colleague that was going to join the meeting, she's a commissioner in cases in Kent County Council, and really at the moment I would say we're joined at the hip. But we are still two different organisations. What we need to start doing is actually just having, one team, one organisation, and a bit more joined up. I would say we're a bit more advanced in some areas. So certainly we've spoken about it with children's commissioning and with mental health commissioning. And I think with children's we probably will get there in this year at some point. But full budget's fine, but it's the commissioning bit that will work.
Okay, thank you.
Thank you. Nick, what are your thoughts and reflections for having heard Sue talk about what's going on in
Yeah, it was very interesting actually. I think there were a couple of observations that I had, and I think I asked Jay the question about capacity review and how the HR are reflecting upon the demands over the future, and I think you've probably got in Kent, particularly in the areas of Ashford, even more of an acute problem, haven't you? Because there is such exponential growth in the population, and it's all it's infrastructure development. So I think that there's a question about there for you, for me, sorry, about that. But the other thing, I think one of the themes that it strikes me about integration is that it's and you touched on it a little bit in the presentation in workforce development, is it's about behavioural change. And one way to, from my perspective and my experience, one way to deliver integration and to actually make it real is to inform and deliver behavioural change across the workforce. So I was interested in, more so than the population one, but I was interested in just understanding where you are with that.
Well, I'd say where we are with that. We've had some successes and we've had some disasters. Our successes have absolutely been getting the people on the shop floor working together. I mean, I'm a sort of great believer in actually if you get those people in a room working together, by default they'll start solving the problems out themselves without anybody from on high doing it for them. So that's been good for us because we've got the social care teams and the integrated teams and the district nurses teams all in one room working together, and they've really driven that process themselves, and really that's been much better than trying to get sort of a group of senior managers in the room and sort of integrated. So I think that's really our lesson, is that trying to empower those people that are actually delivering some of that work to take something forward. So example we had the other day is in one of our community hospitals is rather than me going in and dictating what the specification will be like, it's just saying, well, this is the remit, work it out yourselves, I'll come back in a month and you tell me how it's going to happen. And they really rise to that challenge, I think. On the other hand, is not all teams are like that. Some of them are a little bit suspicious, what you're doing, a little bit it's just taking that leap of faith, isn't it? And I think we need to nurture them through that process.
Okay, thank you.
Okay, thank you, colleagues. I'm going to draw us to a close in a couple of minutes. Before I do that, I'd like to ask Ronan for some last sort of reflections and thoughts having heard a lot of the conversation, whether or not you could just help us draw this together a little bit right here at the end, and then I will just close us in a couple of minutes' time. So, Ronan, would you like to share with us some of your thoughts and reflections?
Sure. Thanks, Matthew. I mean, in terms of just kind of the lessons I draw from this really informative and interesting discussion, I mean, one of the key sort of objectives of monitors' engagement in integrated care, especially from the perspective of the department that I work in, which is the Cooperation and Competition Directorate, is just to ensure that commissioners feel empowered to take these steps towards integrating the different levels of the chain, so whether it's working more closely with GPs and federations and secondary care providers, and also that they don't feel stymied by the new regulations that are in force in the context of procurement and patient choice. So it's really often a case, from our perspective, of trying to myth bust where there are actual obstacles and where actually there's a lot of perceived obstacles to integrated care which are actually not there on closer examination. So from my perspective, it's really interesting to see that in some ways the most success in relation to integrated care is where you do have buy-in at the local level, where you do have a very well-developed I suppose you could call it business case, which draws on the different sort of sources of information, whether they come from patient groups or from clinicians themselves. I mean, I was really heartened to hear about, actually having, for example, GPs embedded in the A&E departments and vice versa to some extent, and the various projects that you've referred to sort of help all the different workers at the different levels of the chain, so whether GPs or social care workers or other clinicians, to understand the different challenges. So, for example, with frail elderly, I think was referred to a little bit earlier, helping to understand an end-of-life care, to understand, the practical challenges that are faced. But again, I mean, I was just really interested and heartened by especially in relation to PHR, with understanding the sort of local needs of the population and how they may be different across the different demographic groups. So we're really sort of on hand to help in any way we can in navigating those practical problems. I mean, just from my perspective in the CCD Directorate, we are interested in so Sue was discussing the fact that there was only one provider in her local area, and that was presenting some problems, but also some opportunities to work more collaboratively. And so, we'd also be interested in whether there's opportunities there to look at either providers further afield, other FTs, other independent providers, and whether that might be a useful lever to actually get the sort of established incumbents to the table and to sort of encourage innovation there. But actually, I think Sue alluded to that a little bit with her reference to the fact that they were, a lot of patients were actually going to central London, and there might be an opportunity to repatriate that care. And I think that's really sort of encouraging to hear that, that might be a useful lever to encourage the sort of existing providers to come to the table and work on sort of integrated care solutions.
Okay, thank you very much. I'm going to draw us to a close now. We have focused our conversation this evening on commissioning, and we've discussed joint commissioning and shared outcomes and sequins and DESs and LESs and a whole range of commissioning practices and ideas. But as we could expect, we have gone on to talk about workforce development, virtual care records, behaviour change, shared vision and values. And at the heart of pretty much all of the conversation has been how we have created relationships, trust and engagement with primary care, with secondary care, and also importantly with patients and carers and communities. Thank you, colleagues, for your input and for your questions and your encouragement to one another. And I think we will close our broadcast now. And thank you all again and wish you a very good evening. Thank you.
Thank you.
Thank you.